Hello everyone, I am Dr. Rohan Khandelwal. I am your Marrow General Surgery SS faculty, and I'll be covering up the NEET SS recall in two parts. Today is part 1, then I'll be covering up part 2 as well, and I'll be releasing another video for the potential questions and topics related to INI SS exam. So the general surgery exam of NEET, now you know the pattern has changed and it was an exit level paper. And my understanding of the paper was that almost 75 to 80% was very basic paper which you could have solved with your PG knowledge as well. It was those 20% questions which really made the difference in the rankings, and those 20% questions mainly came from Bailey and Sabiston. Right? If your core knowledge is of Bailey and Sabiston, that is good enough. For certain topics like thyroid, breast, I would recommend Schwartz as well. Otherwise, Bailey and Sabiston are sufficient to prepare for the NEET SS exam. Especially the latest Sabiston, you should go through the tables as well. So moving on to the recall, first let's do the questions related to trauma and shock. There were at least 8 to 9 questions related from shock and trauma, which is always an important topic. Also for INI SS, this is a very important topic. Now, following road traffic accident, a person lost 1 liter of blood and has tachycardia but normal systolic BP. What class of shock is this? So, if you remember in the shock module, I've already covered this in great detail. We know that in class 1, nothing changes, everything is normal. In class 2, there is going to be tachycardia. There is going to be tachycardia, but systolic BP is going to be normal. In class 3, systolic BP will start to fall and tachy will persist, and class 4 is when everything is unrecordable. So this is just a gist of the 4 classes of hypovolemic shock, and we know the amount of blood volume loss is 0 to 15%, 15 to 30%, 30 to 40% in class 3 and more than 40% in class 4. And you just have to add 500 cc every time. So this is 500 cc, this is still 1 liter, this is still 1.5 liters, and this is more than 2 liters. So 1 liter, multiple clues how you can reach to the answer. 1 liter would be class 2, this I have told you. There is tachycardia and systolic BP is normal. That means it is a compensated type of hypovolemic shock. Both the ways you can reach to the answer. This type of question is frequently asked in the exam. Sometimes they'll ask type 2, class 2, sometimes they ask class 3. Here the answer was class 2. So it was based on this table, which is the table which covers up the 4 types of hypovolemic shock, 4 classes. I've already covered it in detail. Now one more thing which I want to highlight here is as the shock classes progress, there is more amount of acidosis in the body as well. And how do we document acidosis? We document acidosis using base deficit, right? So more the base deficit, more negative the base deficit, right? So more negative the base deficit, right? More severe is the shock. More severe is the shock. So there was another question based on this. Base deficit suggestive of higher mortality. So I told you more the base deficit in minus means more the acidosis, more is going to be the mortality. So the answer here is going to be 7. And you can see in class 1 it is 0 to minus 2, in class 2 it is minus 2 to minus 6, in class 3 it is minus 6 to minus 10, and it is minus 10 or less in class 4. So higher the base deficit, more is the acidosis, more is the risk of mortality. This is a very, very important table from which every year, every exam of SS, at least 2 questions are asked. So you should be well versed with this table. Another question was regarding MIST and AMPLE full form. Now this is given in Bailey. MIST and AMPLE are 2 pre-hospital checklists which we cover up in all trauma patients. Okay, so this is what we ask the patient, the mnemonic is AMPLE, and from the first responder we ask about MIST. So this information is conveyed to the emergency team so that they are better prepared to handle the patient. Now MIST includes, M is for mechanism, I is for the extent of injuries, S is for the signs and symptoms, and T is for the treatment given. From the patient, we ask about ample. A is allergies, M is medical conditions, P is past history, L is last meal, and E is events leading to trauma. So these are the two things which we find out in the pre-hospital care. This was also asked in the exam. There was a question from injury to the neck, so trauma neck zones. The question was penetrating injury to zone 3 of neck in a 40-year-old. What is the further management in these patients? So the question was regarding trauma neck zones. Now there are 3 trauma neck zones. Zone 1 is from the thoracic inlet to the cricoid cartilage. This is zone 1. Zone 2 is from cricoid to angle of mandible. And zone 3 is from the angle of mandible to base of skull. That is zone 3. Now you need to know that zone 2 is the most exposed zone. It is also the most commonly injured zone and the most surgically accessible zone. Maximum mortality is with zone 1. Now in zone 1 and in zone 3, you have major vessels which are there. So zone 1 and zone 3, you have major vessels which are there. So every time there is a zone 1 or a zone 3 injury, if there is a zone 1 or a zone 3 injury, we always do an angio first. Right? We always do an angiography or a CT angiography before we proceed for any intervention, and the intervention also in these cases can be embolization. If that fails, then we are going to explore, because it is not easy to explore zone 1 and zone 3. They are hidden zones. Whereas zone 2, majority of the patients, almost 80% are managed conservatively. 80% patients are managed conservatively, but if you have hard signs of neck trauma, then we need to do exploration. And what are the hard signs of neck trauma? They can be expanding hematoma, hypotension, neurological deficit, right? Or if there is subcutaneous emphysema. All these are hard signs where we need to explore, otherwise we can manage these patients conservatively. So here it was zone 3 injury. So in zone 3, before any exploration, we will always do CT angio. So zone 1 and zone 3, we will always do CT angiography. There were 2 questions regarding CSF rhinorrhea. Now we know CSF rhinorrhea, if there is injury to the anterior cranial fossa, that is you have the cribriform plate. If it is fractured, there can be CSF rhinorrhea. Now the first question was, how do you identify CSF rhinorrhea? How do you differentiate it from blood or epistaxis? And we know the definitive test is beta-2 transferrin, which is present in CSF. This was a straightforward question. You also know about the target or the halo sign, where if you collect that fluid coming from the nose on a handkerchief or on a blotting paper, you will get a central circle of blood and you will get an outer circle of CSF. This is known as the halo or the target sign. Now majority of the times this CSF rhinorrhea will stop spontaneously, and all that is required is antibiotic prophylaxis. We usually use a 3rd generation cephalosporin in these patients. Okay, we use a 3rd generation cephalosporin. That is what is done. Now there was another question where they said that there is road traffic accident and there is ethmoid fracture with CSF rhinorrhea, which is persisting for 10 days. So we usually give a time period of 7 days or 1 week for conservative management, where we just give antibiotics, and within 7 days this leak stops spontaneously. But in this question, if leak persists, if the leak persists beyond 7 days, then we first carry out a diagnostic endoscopy and we will try to carry out endoscopic repair. If endoscopic repair fails, then we think about doing an open repair. So that is the protocol. First 7 days, just antibiotic prophylaxis, third generation cephalosporin. If it persists beyond that, then we will do endoscopy and we are going to do repair. So the correct answer here is D. The next question was, there is a penetrating injury to the heart. What is the best exposure? Now, if you remember the module on thoracic trauma, I have told you that if we have to carry out an emergency thoracotomy in thoracic trauma, we prefer an anterolateral thoracotomy, right? We prefer an anterolateral thoracotomy. That is what we prefer. So the question, you need to understand that stab injuries most commonly will be to the left side of the heart, and to expose the left side of the heart, mainly the left ventricle, we will carry out a left anterolateral thoracotomy. So that will be the correct answer here. Left anterolateral thoracotomy is what we are going to do to expose the heart. So that is the answer, left anterior thoracotomy. The dose of methylprednisolone in spinal cord injury as per the NEET 3 criteria. So this was a tricky question which is there in Sabiston. It is there in one of the tables. So you need to know about the National Acute Spinal Cord Injury Studies. There are two studies. You have the NEET 2 and the NEET 3. It is the NEET 3 which we are following these days. And you need to understand that if there is spinal cord injury, we do use methylprednisolone. Whereas in traumatic brain injury, so two different things. Traumatic brain injury, there is no role of steroids, but in traumatic spinal cord injury, there is a role of steroids. And we give it according to the NEET 3 criteria, which says that 5.4 mg per kg for 48 hours methylprednisolone is better, and you can see that studies have shown that the 48-hour protocol is better than the 24-hour protocol. So these were the questions which were related to trauma, and as I told you, at least 8 or 9 questions were there from trauma, and you should know about them. Moving on to the questions related to breast surgery, and this time in the NEET exam almost 6 to 7 questions were there from breast surgery, mainly from breast cancer, but there were questions, 1 or 2 questions from benign disorders as well. So breast and thyroid are also very important. Thyroid also, there were at least 5 to 6 questions from thyroid in the NEET exam. The first question was very straightforward. I think so even an undergraduate could have answered this. Which of the following is not a risk factor for breast cancer? So we know that fibroadenoma, which is a benign condition, or a breast mouse, is not a risk factor for breast cancer. Now you should know that all these simple questions you can't afford to go wrong, because if you go wrong in these simple questions, then you're out of the race. So these simple questions, please read them properly and choose the answer. These questions you can save a lot of time as well, and they are easy questions which most of the students are going to get correct. So avoid making mistakes in such questions. Now, this was based on the DuPont and the Page classification, which tells us what is the risk of cancerous conversion in breast disorders. We know no increased risk is in cysts, ductictasia, fibroadenomas, mastitis fibrosis, and mild hyperplasia. 1.5 to 2 times relative risk is with papillomas, sclerosing adenosis, and moderate or severe hyperplasia. And 4.5 to 5 times risk in atypical ductal and atypical lobular hyperplasia. So the answer to the previous question was a fibroadenoma. Pregnancy associated breast cancer is a standard question which is asked almost every year in the SS exam, right? It is a very important concept based question which is asked. So this time they had asked a 25-year-old female, comes at 12 weeks of gestation. So she's finished the first trimester, entering into second trimester with a 2 centimeter biopsy proven malignant breast lump without any axillary lymph node involvement. What are the correct treatment options? So termination of the pregnancy is probably the last thing which we think about when the patient has a pregnancy associated breast cancer. Now wait till completion of pregnancy. Of course, we are not going to leave a cancer untreated for 2 trimesters. So this is also out. So now we have lumpectomy plus axillary dissection and chemotherapy, or lumpectomy plus chemotherapy, right? So, of course, in these patients, we will carry out a lumpectomy plus axillary clearance, and then we can give chemotherapy. Chemotherapy we know is safe in second and third trimesters. It should be avoided in the first trimester. You should know that you might think that why are we doing a lumpectomy, because we have to give radiation. So yes, we can give radiation after pregnancy. So we do the lumpectomy, then the patient undergoes chemotherapy for the next 2 trimesters, a chemo will get over, and then we will give radiotherapy once the child is delivered. Okay. So BCS is not an absolute contraindication in pregnancy, because we can give radiotherapy after delivery provided the patient is being detected in the second or the third trimester. Okay. Hormonal therapy you know is contraindicated in all trimesters. So which is not a risk factor for male breast cancer. Now Klinefelter syndrome we know is a risk factor for male breast cancer. Family history is there, and BRCA2, we know BRCA2 gene is more commonly linked with breast and prostate cancer, right? So this is definitely a risk factor. Gynecomastia is not a risk factor for male breast cancer. Invariably in every exam there is one question from breast cancer staging. It is always there. So breast cancer staging is super important for all the SS exams. This time they had asked staging questions from breast and thyroid, gallbladder, right? So there were hepatoblastoma also, there was a staging question. So at least 4 questions from staging they had asked in this time's NEET SS exam. A 50-year-old premenopausal woman with BIRADS 5 lesion underwent a lumpectomy 2 years back, and now comes with a hard mobile axillary lymph nodes on the same side of the lumpectomy. What is the stage? Now because she has already had a lumpectomy previously, we don't currently know the T stage, we can't predict the T stage. So clinically I am going to write it as TX, CTX, I cannot assess it. We know there are palpable hard mobile lymph nodes which we are assuming are malignant. So mobile lymph nodes are N1, and again I cannot comment on the metastasis clinically, so I am going to write as MX. So it is going to be CTX N1 MX. That is the correct answer here, which we should know about. Now the TNM staging is very important. TX is when the tumor cannot be assessed. TIS is DCIS and Paget's disease. We know LCIS is no longer a risk factor now. T1 is a tumor less than or equal to 2 centimeters. T2 is 2 to 5 centimeters. T3 is more than 5 centimeters. T4 is the one from which a lot of questions have been asked in the exam. Now T4A is extension to the chest wall but does not include the pectoralis muscle. So please remember that T4A is chest wall involvement, barring the pectoralis involvement. Pectoralis involvement does not make it a T4A disease. T4B is skin involvement, and 3 things are included: peau d'orange, ulceration and ipsilateral satellite nodules. T4C is A plus B, and T4D is inflammatory cancer which has the worst prognosis, and inflammatory carcinoma, it is a clinical diagnosis. So if more than 1/3 of the breast skin is involved with PDO, we are going to write it as inflammatory breast cancer. PDO is peau d'orange. This was also a straightforward image based question. So there were at least 15 to 20 image based questions. Mostly they were very straightforward images. Some were tricky, which we will discuss, but majority were straightforward images, right? So they had shown a mammography, and the mammography showed clustered microcalcifications. So we know clustered microcalcifications are usually seen in ductal carcinoma in situ. Ductal carcinoma in situ, and this should have been a core needle biopsy, right? Not FNAC, it should be core needle biopsy, and DCIS is what is going to show you clustered microcalcifications. DCIS, we know the most common type of DCIS is papillary DCIS, whereas the most aggressive type is comedo with necrosis. There was another question related to breast cancer. We had a 30-year-old premenopausal lady with a 1 centimeter lump in the left breast, no palpable axillary lymph nodes. She underwent a lumpectomy. right? So she underwent a lumpectomy and this was cancer. So we have a 1 centimeter cancerous growth for which breast conservation has been done. Now once breast conservation has been done, observation of course is out. If all the margins are out clear, we don't need to do a mastectomy. So you need to choose between radiation and chemotherapy. Now all patients of breast are not receiving chemotherapy. You know there are certain exceptions, right? But any patient who's undergone a breast conservation surgery, this I've covered so many times, any patient who's undergone a breast conservation surgery, it is mandatory to give what? It is mandatory to give radiotherapy. So that will be the correct answer here. Not all patients require chemotherapy. You know, low risk hormone positive patients, we can do certain molecular tests to avoid chemotherapy. Okay, so radiation will be the correct answer here. A 50-year-old lady with breast cancer with good performance status is diagnosed with a 2.5 centimeter solitary brain mets. No other mets are there in the body. Best treatment. So whenever a lady is detected with metastasis, right, we first have to evaluate if other metastases are there or not. In this case, it's a solitary brain met. You know that amongst the various breast cancers, it is the triple negative breast cancers which show frequent brain mets. Okay. Now, solitary brain mets which are there, we are going to treat this patient aggressively. Now, there is a term which you should know about, which has also been asked in various exams, that is oligometastatic breast cancer. Now, oligometastatic breast cancer is metastatic of course, but less than equal to 5 mets are there. Okay. So it has been seen that if less than equal to 5 mets are there, as compared to diffuse or generalized metastasis, these patients with oligometastatic disease tend to do better. They have better survival. So it is said that we need to treat them aggressively. Now this solitary brain mets, we can do surgery and remove the mets. That is the best. If there were multiple metastases, we would have done whole brain radiation or stereotactic radiosurgery. We are going to give steroids because steroids reduce cerebral edema, but that is not the treatment. Okay, that is not the definitive treatment. We are going to of course give steroids in this patient to reduce the cerebral edema, but that's not the definitive treatment. The definitive treatment is going to be surgery. Another question was asked on similar lines. So there were a lot of questions this time in the NEET exam where they were interlinked, where one question I was asking one thing and the follow-up question was pertaining to that only. So a lot of times if you think logically, you can answer the other question just based on the first question findings what you have done. A known case of carcinoma breast comes with headache, undergoes a CT and is diagnosed with the solitary brain mets and is started on IV treatment. What is the best explanation for the above treatment? I told you we start steroids and steroids are being given to reduce the edema. So mannitol, no, steroids reduce vasogenic edema. This is correct. Steroids are the drug of choice for vasogenic edema or cerebral edema which is linked with tumors. Steroids are the drug of choice. In trauma, mannitol was the drug of choice. Traumatic brain injury, mannitol. Tumor related cerebral edema, steroids. Please remember that. Okay, this is very important. Which of the following is not a feature of malignancy? So they escape immune destruction, this is true. They escape apoptosis, this is true. Local invasion and mets, this is true. They undergo autophagy, this is false. They also evade autophagy, right? So these are the features of a malignant cell. I think so this is also from related to pathology, the Robbins chapter on basics of cancer, that is what was asked in the exam. So moving on to the questions asked from thyroid. So this time most of the questions were from thyroid, very few questions from parathyroid, which was very strange because usually at least 2 questions from parathyroid are also asked. And parathyroid is a very important topic for your INI SS exam as well. So thyroid surgery questions, what you need to know for your exam. One was a very straightforward question. This is asked in every exam. They showed a histopathological slide and said that the patient has a thyroid swelling, and you could see the classical orphan aniide nuclei. Now, the histopathological features of papillary thyroid cancer you all need to know about. You need to know that you get orphan aniide nuclei, intranuclear inclusions, and we can see samoma bodies as well. Samoma bodies are these foci of dystrophic calcification which you can see in papillary thyroid cancer. Okay. So, these histopathological features you should know. For medullary thyroid cancer, this has also been asked, the slide has been asked, you can get amyloid rich stroma. So, you will see pinkish material on the slide. Amyloid rich stroma can also be seen. Parafollicular or C cells which give rise to medullary thyroid cancer, they descend towards the thyroid gland along with what? So, these parafollicular or C cells, right, which produce calcitonin, they are derived from the neural crest. They are derived from the neural crest, and the intermediary body which forms after this is the ultimobranchial body. So, from these ultimobranchial bodies, these parafollicular or C cells arise, they secrete calcitonin, and it is these cells which can get converted into medullary thyroid cancer as well. So, another question related to medullary thyroid cancer. A patient with medullary thyroid cancer is planned for surgery. So, there were two questions related to medullary thyroid cancer surgery this time, right. So, this is one. The next one also I will tell you, two questions related to medullary thyroid cancer surgery. At what level of calcitonin will an ipsilateral central neck and lateral neck dissection be indicated? So, normally we know that medullary thyroid cancer is an aggressive cancer, and even if the medullary thyroid cancer is restricted just to the thyroid, we still do a central neck dissection. But there are certain indications where the tumor might not be, the patient might not be having lymph nodes, but we should still do a lateral neck dissection, and that indication is based on the quantification or the quantity of calcitonin. It has been seen that if it is more than 200 picograms per milliliter, then we need to carry out more than 200 picograms per milliliter, then we should do a prophylactic central and lateral neck dissection, in medullary thyroid cancer. One of the indications is if the calcitonin in these patients is between 200 to 500 picograms per milliliter. So, like I said, another question was a male patient with a 1 centimeter nodule. So, a very small nodule in the right lobe of thyroid. FNAC shows it's a medullary thyroid cancer without any neck nodes, right. So, I told you medullary thyroid cancers are aggressive. Had this been a case of papillary, we would have even thought about doing a hemithyroidectomy. Okay, but here, because it is medullary thyroid cancer, the minimum surgery which we are going to do is total thyroidectomy with central neck dissection. That is the bare minimum which you will end up doing in a patient with medullary thyroid cancer. Okay. Whereas if it is a differentiated thyroid cancer, means if it is a PTC or a follicular thyroid cancer, you should know that if the patient is less than 55 years, if the tumor is less than 4 centimeters, if there are no mets, if there is no capsular invasion, then in these patients we can even do a hemithyroidectomy. But in medullary thyroid cancer, we don't do hemithyroidectomies. Now, there was a question regarding the staging of thyroid cancer as well, right. So, the question was a 44-year-old female presents with a 3 centimeter thyroid nodule which is involving the strap muscles with significant lateral neck nodes on the same side. Now, if you remember the module on thyroid, I have covered the 8th AJCC updates in thyroid cancer staging. And it is my request that for all SS candidates, these AJCC updates, the 8th AJCC updates for cancers are extremely important. They are asked frequently in the exam, especially for breast, thyroid, G junction tumors, colorectal cancers. You should know the 8th AJCC updates for these tumors at least. So, involvement of the strap muscles makes it T3B. You can see here T3A is more than 4 centimeters restricted to the thyroid, but T3B is gross extrathyroidal extension into the strap muscles. So the special category has been created that if the strap muscles are involved, it becomes T3B. So that will be the answer here. It is going to be T3B and stage 3. T3B and stage 3 will be the correct answer here. You should also know certain updates that for differentiated thyroid cancers, the age has been increased from 45 to 55 years. What does that mean? Earlier it was said that anyone less than 45 was good prognosis in thyroid cancer. Now we've increased that age group up till 55. So anyone less than 55 is good prognosis, more than 55 would be bad prognosis. Another update for anaplastic cancers is that for all anaplastic cancers previously, whatever the size may be, they all were classified as T4 disease. Even if it was 1 centimeter, it was T4 disease. But now anaplastic cancers are also staged the same way as differentiated thyroid cancers. Next question was, which is not used in thyroid storm. So we know thyroid storm is uncontrolled thyrotoxicosis. The most common cause of thyroid storm has also been asked many times, that is inadequate preparation of a hyperthyroid patient. Now, the drug which we don't use when there is thyroid storm, propranolol we use because it is a beta blocker, propylthiouracil we use, Lugol's iodine we use, aspirin for hyperpyrexia is not used. We are going to use paracetamol, not aspirin. Aspirin can aggravate the features of thyroid storm. So aspirin is not used. Again, a simple question, which of the following antibody tests is not done with respect to thyroid? So whenever we are doing thyroid function tests, as a part of the panel, anti-thyroid antibodies can also be done. Now, anti-TSH antibody, anti-peroxidase antibody, thyroid peroxidase, and anti-thyroglobin antibodies, all these can be seen in Hashimoto's thyroiditis. Anti-nuclear antibodies we routinely don't do in a thyroid panel. So we routinely don't do ANA or anti-nuclear antibodies in the thyroid panel. Again, a very straightforward and a simple question. These are the questions which you can't afford to make a mistake in. Which radioactive isotope is used for the treatment of differentiated thyroid cancers? It is iodine 131. The other questions which have been asked are the half-life of iodine 131, that is 7 to 8 days. And it acts via beta rays. It acts via beta rays. These are the other questions which have been asked as well. So these were the questions related to thyroid. Like I said, there were no questions from parathyroid, but for your future exams and for INA SS, definitely focus on parathyroid. You can expect at least 2 questions from parathyroid. It's a hot topic which is asked in the INA SS exam. Moving on to the general surgery recall questions. So MVOS, mixed venous oxygen saturation. MVOS is mixed venous oxygen saturation in septic shock. This question has been asked many times in the SS exam, sometimes in the PG exam as well. This is based on the surviving sepsis guidelines which are given in Sabiston as well. So these are the surviving sepsis guidelines, and you should be aware of these surviving sepsis guidelines. So these guidelines say that during the first 6 hours of resuscitation, the goals of initial resuscitation in a sepsis-induced hypoperfusion should be that we need to achieve a CVP of 8 to 12, mean arterial pressure should be more than 65, urine output should be more than 0.5 ml per kg per hour, and MVOS in these patients should be 65 or more. This you should remember, and we should try to normalize lactate in these patients, which is elevated because of acidosis in these patients. Okay. So these are the goals which we need to achieve in a patient who has sepsis-induced hypoperfusion. You should remember them for the exam. So shock is a very important topic, and you can see 3 questions which have been asked from shock. I told you about the classes of hypovolemic shock and trauma, then I surviving sepsis guidelines, and now they've asked about modified shock index. So no exam in which shock at least 2 to 3 questions are asked. So definitely revise your topic on shock before going for any SS exam. So modified shock index we know is heart rate divided by mean arterial pressure. Heart rate divided by mean arterial pressure. We had to mark the wrong statement. So we know it is not mean arterial pressure divided by heart rate. It is the other way around. Okay. High score is suggestive of low stroke volume. This is true because high score means there is tachycardia, right? So if there's tachycardia, then the stroke volume is going to be less, because there will be less time for diastole and less filling in the heart. When there's less filling in the heart, there's going to be less stroke volume, okay? Because stroke volume is determined by the end diastolic volume. Low MSI is suggestive of hyperdynamic circulation. That is also true. Predicts mortality better than shock index. That is true. Modified shock index is the most sensitive indicator, more sensitive than shock index. So modified shock index is heart rate by mean arterial pressure. High MSI is low stroke volume, and low MSI suggests hyperdynamic circulation. Flap used for sacral pressure source. So this is a constant thing which was asked in the exam. Bed sores are very important. They had shown an image like this and they had asked what type of flap is this. So this is a rotational flap, okay, a rotational flap where we rotate the flap and we cover up the defect. So this is an example of a rotational flap which is used, and you can use a tensor fascia lata flap for bed sores as well. Tensor fascia lata flap can also be used, and this is based on the lateral circumflex vessels, lateral circumflex femoral vessels. That tensor fascia lata flap can also be used. So pressure sores are very important. You should know the grades. You should know about vac dressing also, which has been asked in the exam. Again, types of wounds, constant question, definitely will be asked, definitely in INI SS. So INI SS, focuses a lot on patient safety. It focuses a lot on emergencies and wound infections. So you should definitely know about it. You should also know the details of the Southampton and the asepsis wound score. Now, bowel injury during lap port insertion with peritoneal contamination. So if there is peritoneal contamination which has occurred, then this is going to become a contaminated wound, right? Because it was an unexpected opening of the bowel. If you're anticipating you're going to open up the bowel and the bowel is prepared, we call it clean contaminated. But if there is unexpected opening of the bowel and there is contamination, we call it a contaminated surgery. So this is a very, very important table which you need to know. Clean wounds where no viscous is opened, the risk of surgical site infection, these values you need to remember for the exam. They were asked last year as well. So with antibiotic prophylaxis it is 1 to 2%, without antibiotic prophylaxis also it is 1 to 2%. Clean contaminated is when the viscous is opened but there is minimal spillage, no contamination. If prophylaxis is used, 3%, and if prophylaxis is not used, it is 6 to 9%. When there is spillage and inflammatory disease, contaminated wound, with prophylaxis it is 6%, without prophylaxis it is 13 to 20%. Dirty wounds, when there is pus or there is perforation, then with prophylaxis it is 7, without prophylaxis it is 40%. So these values you need to remember. You need to remember the examples of clean, contaminated and contaminated dirty wounds as well. Another question which was based on a flap, they had shown a DP flap, a deltopectoral flap. Now if you remember your module on plastic surgery, the basics of plastic surgery, I have shown you all these flap images and I have shown you a deltopectoral flap. Deltopectoral flap can be used after oral cancer surgery. Now DP flap, deltopectoral, means the deltoid and the pectoral muscle, we lift it from lateral to medial and we swing it based on the pedicle which is situated medially. Now what is the pedicle which is situated medially? So the pedicle is going to be based on the perforators of internal mammary vessel. The perforators of internal mammary, that is what will carry the DP flap. 2 questions on flaps were there. Actually 3 questions. I told you about the bedsore flap question. Then there was a question regarding DP flap, and they had shown They had asked about Abbé-Slander flap as well. This has also been asked many times in the exam. Abbé-Slander flap is used for lip reconstruction, lip and angle of mouth reconstruction. We use the Abbé-Slander flap. You should know about this as well. This is the Abbé-Slander flap. It is based on the labial vessels. Now I am going to show you the flap images because INI SS also definitely 1 or 2 questions are asked from plastic surgery. Skin grafting is super important. Every year there is a question from skin grafting and at least 1 question from flaps as well. So this is a rhomboid flap. A rhomboid flap can be used for this was after basal cell carcinoma surgery or pilonidal sinus surgery. Very important is pilonidal sinus surgery, that has been asked in the exam. A bilobed flap can be used for tip of nose reconstruction and a bipedicle flap can be used for eyelid reconstruction as well. These are the PMMC and the DP flaps which are there. This one is the deltopectoral flap, which I have told you is based on perforators of internal mammary. This is pectoralis major myocutaneous flap, which is based on the pectoral branch of thoracoacromial, pectoral branch of thoracoacromial vessels. And this is the most commonly used flap by a head and neck surgeon, the PMMC or the pectoralis major myocutaneous flap. You can see that this is the pectoral branch of the thoracoacromial, another patient with the PMMC flap. Abbé-Slander I have already told you. Carpendasiac flap is also used for lip and angle of mouth reconstruction. This question has also been asked in the INI SS exam. This is the latissimus dorsi flap, which can be used for breast reconstruction. And you can see here, this was a case where I had done a LD flap. I have marked it at the back. This is the marking of the LD flap on the back. We swing it forward. You can see here, this is the dissected LD flap and I just swing it forward and I can use it for reconstruction. The LD flap is based on the thoracodorsal pedicle. LD flap is based on the thoracodorsal pedicle. The TRAM and the DIEP flap, you should know that DIEP flap is the best flap for breast reconstruction. It is the best flap for breast reconstruction and this stands for deep inferior epigastric artery, deep inferior epigastric artery perforator flap. So, deep inferior epigastric artery perforator flap, this is the DIEP flap. And why is it better than TRAM? Because in TRAM we remove the muscle as well and there can be more abdominal wall morbidity, more chances of incisional hernia. Whereas in DIEP we are not removing the muscle, so abdominal wall morbidity is less. That is why DIEP is the best flap for breast reconstruction. Another patient of mine where TRAM was done, so you can see just by looking at the image, you cannot differentiate between DIEP and TRAM. You would have to read the OT notes to see which flap has been done. This is a radial artery forearm flap, another case where one of my friend had dissected this radial artery forearm flap. This is used for again oral reconstruction after oral cancer surgery. This is a free fibular flap. Free fibular flap is based on the peroneal vessels. A free fibular flap is based on the peroneal vessels and this is the best flap for mandibular reconstruction. This is the best flap for mandibular reconstruction. This has also been asked many times in the exam. So the next question was again a recall based question. If it was, if you have read about it, if you remember it, you could have answered it, but it's actually these questions which sometimes separate people with great ranks from mediocre ranks, but again you can't prepare for such questions. These are just questions which you can just remember using your long-term memory. So interleukin 2 is released by which cells? So interleukin 2 is released by T lymphocytes. That is what you should remember for the exam. Again a simple question, the range of normal central venous pressure. So the range of normal central venous pressure is 5 to 8 millimeters of mercury. Now they had given two options here, centimeter of water and millimeters of mercury, and some students got confused there, but you should know that it will be millimeters of mercury. The Harris-Benedict equation is based on which all factors? So the Harris-Benedict equation is used for calculation of caloric requirement, and you can see that the Harris-Benedict equation is different for men and different for women. It includes your weight in kgs, height and age. So weight, height, age and sex, these are the 4 parameters which are included in the Harris-Benedict equation, which is used for caloric requirement. So the Harris-Benedict equation is based on age, sex, weight and height, which is used for caloric requirement. Another simple question was regarding INR. They had asked what is the formula for INR. INR we know is International Normalized Ratio, and it is prothrombin time of patient divided by prothrombin time of control, and you have to multiply it with the International Sensitivity Index, right. So that is the formula for INR, and we need to know that the INR should be less than equal to 1.4. At this INR, we can carry out a surgery. If the INR is more than 1.4, then your anesthetists are going to create trouble for you and they will not allow you to carry out elective surgeries till the INR is corrected. How do we correct raised INR? So the fastest way of correcting raised INR, this has also been asked in the exam, we can either use prothrombin factor concentrates, we can either use prothrombin factor concentrates, or we can use fresh frozen plasma or FFP. These are the two which we can use to correct raised INR. After a long surgery, patient developed petechial patches in the forearm, platelets were reduced, INR is severely raised, APTT is raised, TLC is normal and HB is 8.1. You can see these are telltale signs of consumption coagulopathy, which we can see in DIC, right, disseminated intravascular coagulation. That is why the platelets are reduced and the INR is raised. This can happen in sepsis and after major surgeries. This was a very straightforward question which was asked. It has been asked multiple times in the exam. Raynaud's phenomena, what is the color change which is seen? Now Raynaud's phenomena, the color change which is seen is white, blue, red. You can see Raynaud's phenomena, you will get white, blue and red. That is the correct sequence. Again, a very straightforward question. And another question which has been asked in the exam regarding Raynaud's is the difference between primary and secondary Raynaud's. So you should know primary and secondary Raynaud's. Primary Raynaud's is more common as compared to secondary. Secondary is the one which is associated with autoimmune disorders like rheumatoid arthritis, SLE. So all the autoimmune diseases, you will get secondary Raynaud's phenomena. Pharmacological treatment is frequently required in secondary Raynaud's, and complications are also more in secondary Raynaud's. You should also know what has been asked in the exam. The drug of choice for Raynaud's disease is calcium channel blockers. That also you should remember for the exam. Gustatory sweating. So gustatory sweating we know occurs in patients with Fraze syndrome. So Fraze syndrome is after parotidectomy. The nerve implicated is the auriculotemporal nerve, and these nerve fibers will start supplying the skin after superficial parotidectomy. And there you can get gustatory sweating when there is sweating in response to smell and taste, right? And we can do the starch iodine test to confirm the diagnosis, and the management would be in the form of Botox or tympanic neurectomy. So this is Fraze syndrome or gustatory sweating, which you should know for the exam. Also nerve injuries related to parotid gland are extremely important for the exam. So marginal mandibular nerve, you will get drooping of the angle of the mouth, that is marginal mandibular nerve injury. Then if the greater auricular nerve is injured, you will get anesthesia over the region of the beard. So third one, auriculotemporal, is implicated in Fraze. It is not injured, it is implicated. So these three you should know, because invariably one of these three always finds its way in the INA SS exam. So you should know about nerve injuries pertaining to parotid surgery. When does lipodermatosclerosis occur? So lipodermatosclerosis occurs when there is a long-standing venous problem or varicose veins. You can get lipodermatosclerosis. In lipodermatosclerosis, you get an inverted champagne bottle appearance. Lipodermatosclerosis, you will get inverted champagne bottle appearance, where you can see that the skin becomes shiny and the subcutaneous fat that atrophies. So it gives an inverted champagne bottle appearance, and this is a sign of chronic venous disease or varicose veins. These clinical features of varicose veins are also important. You should also know about atrophy blanche and corona phlebitictasia. These also can be seen in chronic venous disease. The normal venous pressure in a person's ankle when they are standing, this question is straight from Bailey. The answer is 90 to 110 millimeters of mercury, again directly taken from Bailey. And normally when we start walking, the pressure would reduce. But if there is ambulatory venous hypertension, that means when the patient is walking and the pressure keeps on increasing, that is what can predispose to chronic venous disease or varicose veins and venous ulcers. What is the order of subclavian artery, subclavian vein, scalenus medius and anterior on the first rib? This was an anatomy based question, and if you see the cut section, you can see that you will have the the vein first. You can see the vein, then the scalenus anticus muscle, then you have the artery, you have the brachial plexus, and then you have scalenus medius posteriorly. So this is anterior to posterior. You will have the vein, the scalenus anterior, the artery, the brachial plexus and the scalenus medius. That is the correct order of the arrangement of the structures. There was a question that a patient with pulmonary tuberculosis has pleural effusion and is now presenting with grade 2 empyema, right? Stage 2 empyema this patient has. What is the treatment? So to answer this question, you need to know the stages of empyema, which are clearly mentioned in Bailey as well in the thoracic surgery module. The phases or the stages of empyema: you have the exudative phase where there's thick pus and there's fever. You have to do aspiration plus antibiotics. There are no lung changes. Phase 2 is thickening of pus in the pleura. Aspiration becomes difficult, but this is what has to be done here. You need to give antibiotics and you need to put in a pigtail catheter to drain out this pus, or you put in a chest tube to drain out this pus. Phase 3 is when things become even more difficult because there is fibrosis now, because whatever inflammation was there, if it undergoes fibrosis, there is thickening of pleura, the lung becomes entrapped, and now we have to do stripping of pleura or VATS, that is video assisted thoracoscopic surgery, or we need to carry out a decortication. Right. So here it would be antibiotics and drainage for phase 2 empyema. That is what we carry out. This is what empyema looks like. On CT, you can see the collection here. They've already given a history as well. Pheochromocytoma also, usually one question is asked in the exam. The most common clinical manifestation of pheochromocytoma, they had asked the most common clinical manifestation of pheochromocytoma, and the most common clinical manifestation is hypertension. If they had asked the most common symptom, then you should have marked headache, but clinical manifestation is hypertension, which is usually episodic. So we know headache is the most common symptom of pheochromocytoma. The most common clinical feature is hypertension. Majority of the times it is episodic. The screening test is 24-hour urinary VMA or metanephrines, but the most sensitive test is plasma-free metanephrines, which are there. MRI is the imaging investigation of choice, and you get the light bulb sign. And for extra-adrenal pheochromocytomas, we do a gallium dotatate scan. So that is the imaging investigation, but for pheochromocytomas, we get the light bulb sign on MRI. So this was the first part of the recall question. You know the treatment for pheochromocytomas. We first give phenoxybenzamine. So, first alpha blockers followed by beta. We never give beta first, we first give alpha and then we do surgery. So, this was the first part of the recall session. I will record another video on the recall of NEET SS. I've been telling you about the important topics for INA SS. I'll also make a separate video regarding the potential questions and the topics for INA SS, which you should definitely do in the last few days leading up to the exam. All the best. Thank you.